heart failure with a hidden surprise that was revealed in pre-cabbage workup. So let's look into the history. He was a 60 years old male who was admitted for cabbage for multivessel GDMT refractory coronary artery disease. He has history of worsening shortness of breath, orthopnea, with gradual decline in functional capacity for the past 2 months. There was no history of fever. He was known to have hypertension and ischemic heart disease with severe multivessel coronary artery disease and previous history of intervention to LAD and RCA. A recent coronary angiogram showed critical disease in mid-LAD with totally occluded RCA right from the ostium, for which CTO intervention was attempted with pilot 200 PTCA wire, but it was failed and patient was later referred for surgical consultation. Blood workup showed creatinine 2.1, ALT 347, PT 15, HP 11, and TLC 9. On examination, we could find a harsh continuous murmur on right sternal border with bilateral 2 plus pedal edema and distended neck veins, with the ECG as shown, showing T wave changes, ST changes, inferior and lateral leads predominantly. So, moving forward. Okay, so on the left side of the screen, you can see the coronary angiogram images that show a total ostial occlusion of the RCA, that is right from the ostium. On the lower side, this is the LAD that shows severe stenosis that just follows the stent that was previously placed. Moving to the echo images, this is the parasternal long axis view, which shows grossly normal mitral and aortic valves, grossly normal chamber sizes, and a little bit reduced kinesis at the base. On the right side, as we can see, when aortic valve area is interrogated with color Doppler, we can see backwards color flow turbulence staying diastole, suggesting AR that is around mild to moderate in magnitude. Here we can see some measurements with the aortic root measuring around 30. It is 33.5 millimeter, and ascending aorta is 39 millimeters. That is slightly dilated. So moving forward. Okay, so this is the parasternal short axis view. We can appreciate dryly flat aortic valve. Now, when the window between sinus of Valsalva and the right heart is interrogated with color Doppler, it shows clear color flow signal from sinus of Valsalva to the right heart, that is both between systole and diastole. So, although not validated for this kind of shunts, yet kind of what I would say vena contracta was measured for this shunt that measured 6.5 millimeters, suggesting a significant sized shunt. Again, a better elaborate view that shows a clear color flow signal which can be clearly appreciated directed from sinus of Valsalva to the right atrium, and that is mingling with the TR jet. So this was most probably the secret behind worsening heart failure in the context of the history that I have told you, which was attempted PCI to RCA with a heavy PTCA wire. Moving forward, so when the same field was interrogated with continuous wave Doppler, we can well appreciate continuous flow during systole and diastole, and that is what corresponded to continuous murmur that we found on our examination. Right on the right side, you can see the TR jet, which is alongside. So at this point, echo diagnosis of RCA to sinus of or sinus of Valsalva to RF fistula was given, that in the context of history was most likely attributable to attempted RCA intervention with a heavy PTCA wire. CT confirmation could not be done because there was ongoing AKI, and after the informed consent, the surgeon proceeded with surgery. So, surgery was performed that showed and confirmed a fistula rising from sinus of Valsalva near the RCA ostium that was draining into right atrium. It was repaired, followed by grafting of the coronary vessels. And now, right after the repair was performed, to re-ensure the adequacy of repair, intraoperative echo images were taken. This was our area of interest from which previously leaking was taking place. Here you can see. Now, when this area is interrogated with color Doppler and continuous wave Doppler, we can appreciate that the area that was previously showing leakage is now okay and there is no flow. When interrogated with continuous wave Doppler, you can see that the flow that was both during systole and diastole has now vanished. So no residual flow is found, and although repair was done, but post-operative course was complicated by coagulopathy, bleeding, and multi-organ failure, and the patient unfortunately could not survive. So at this point, let's have a look of what we know about aortoatrial fistulas. So it's a very, very rare entity with its true prevalence less than 1%, is somewhere between less 0 and 1%, that is still unknown. A systemic review, however, was conducted of 136 reported cases of aortoatrial fistula that were published till 2019. Out of those, 88% were found to be acquired and 12% were found to be congenital. Most of these were aorto-right atrial, and amongst the acquired etiologies, infective endocarditis was top of the list, followed by aortic aneurysm complicated with a dissection. 15% of these were related to cardiac surgery. Now it's a significant number, but this is cardiac surgery. But only 5 cases out of these 136 cases for which systemic review was performed, only 5 cases, that was 3.16%, took place due to cardiac catheterization or stent protrusion. But wait, it's still not the left heart catheterization. We can see it onwards. So treatment is surgery in most of the cases when symptomatic and when intervention is needed. So although, as I said, cardiac surgery has been listed among the common causes of aortoatrial fistulas, still percutaneous cardiac catheterization falls among the rare causes, and fistulas have been reported with ASD and PFO closure and IVC stenting. But speaking of percutaneous coronary intervention, it is very, very rare. With till date only one such case report that has reported the formation of aortoatrial fistula as a late complication of PCI and displacement. So, what's our bottom line that we get from our case as well as the relevant literature that we found about this is only 3.1% cases of aortocardiac fistula took place due to percutaneous catheterization procedures. However, none of them was due to coronary angiography or PTCA. Only one reported case of RCA to RF fistula to date as a late complication due to RCA stenting, as opposed to early or immediate complication that we narrated in our case. And there are cases, but a very limited number, which report iatrogenic coronary to cardiac chamber or to atrial or ventricular fistula as a complication of right heart catheterization. The one that I mentioned before, that were about the right heart.
Babar.
So, this was my case. Thank you very much.
Good answer.